Hi everyone. This is the lecture for Lab 4. In this lecture, we will look at the Asia classification or Asia impairment scale for spinal cord injuries. We will look at dermatomes and what they are and how to do a dermatome assessment and how they guide the evaluation and treatment of the person with spinal cord injury. We will also look into the different ways to assess sensory motor components after a neurological diagnosis or spinal cord injury. We will, in addition, look at the traditional and the contemporary mode or motor learning principles for motor recovery. Now, when I go through these PowerPoints, I'll cover the areas that are more important for us to know, and which probably is majority of it. But if you have any specific questions after listening to this lecture, and if you need anything clarified, feel free to email Dr. Glover and I, or bring it to class to the next lab, and we'll be more than happy to answer and clarify anything. Now, the spinal cord. The spinal cord is the liaison between the body and the brain. So what that means is that impulses traveling from the brain to the muscles go through the spinal cord, and sensory information coming from the body to go up to the brain goes through the spinal cord as well. So that is the afferent pathway and then the efferent pathway. Dermatomes. So dermatomes are areas of the skin on our bodies that rely on specific nerve connections on our spine or from our spine. So if you think of that, then dermatomes are essentially a map, right? So they, as you can see on this screen, the sensory capacities of different parts of the skin are associated to a different nerve root, a specific nerve roots from a specific part of the spinal cord or vertebrae. Now, because they are connected with a specific nerve root from a specific vertebrae, this allows the healthcare provider to detect and diagnose conditions or problems affecting the spine at this specific region. The Asia Impairment Scale is a scale used to classify the severity of injury as well as the level of injury. Now, or the severity of injury. In a complete Asia A, there is no sensory or motor function preserved below the neurological level. In an incomplete Asia B, or Asia B, C, D, and E are incomplete. In an Asia B, the sensory capacity is intact below the neurological level. However, the motor function is not. In Asia C, motor function is intact. However, the grade is less than 3. In Asia D, motor function is intact, but the grade is more than 3. In Asia's E, although there is a spinal cord injury, the person is neurologically intact. Based on the level of injury, we would expect to see certain muscle groups being spared and certain movements being present. At a C5 injury, oftentimes the biceps are preserved, and you would see the person has, elbow flexion abilities. At C6, wrist extension may be preserved. At C7, triceps, and so on. At T4, movement above the nipple line are intact. At T10, above the belly button, and so on. Now, this actually shows the color coding of the spinal cord to show what level of a spinal cord or what vertebrae or the nerve root that comes out of a specific region or vertebrae is associated in innervating the different parts of the skin. There are two types of spinal cord injuries. There's the incomplete spinal cord injury, which is the most common, and there's the complete spinal cord injury. In an incomplete injury, some messages are going to be getting through that below the injured level to essentially innervate the areas of the body that they're innervating. So some messages are going to pass through that area from the brain essentially. And then of course, efferent pathway, right? So going up to the brain as well. In a complete spinal cord injury, there is full paralysis below the level of injury because of the extent of the damage to the nerves. As we've discussed in a previous slide, or not slide, but previous presentation or lecture, I should say, there are upper motor neuron injuries, and then there are lower motor neuron injuries. The upper motor neuron injuries are associated with injuries to the brain, to the spine, into the spinal cord above the level of lumbar 2 or L2. And then, of course, the lower motor neuron injuries are often associated by the peripheral nerves and sacral segments, particularly ACE2 through ACE4. There's a video that we will likely watch in class. All right, so now we're going to transition into sensory motor assessment. So when we look at sensory capacities after a spinal cord injury, one of the things that we'll be looking at is a dermatome or a dermatome assessment. A dermatome assessment is a sensory test, and in that sensory test, it is used to determine how well the spinal nerve roots are functioning. Now, if during a dermatome assessment, if the sensory changes follow a dermatomal pattern, it likely is an issue with the nerve root that is involved in innervating that specific area of the skin. Now, if it doesn't follow dermatomal distribution, it may indicate other peripheral nerve injuries. The ASIA scale, as I talked about earlier, that allows us to determine the severity of injury, of course, and based on the kind of movement patterns that we are seeing and based on the kind of sensory capacities that are still preserved or intact. Of course, coordination assessment would allow us to determine what kind of movement and how fluid the movement is that is intact. Range of motion assessment is going to be important to understand how much active motion a person has, how much passive motion a person has, in order to utilize the active range of motion for functional tasks, and then from passive range of motion standpoint, in order for us to have a baseline and make sure that we maintain that passive range of motion through different kind of exercise programs. Manual muscle testing is an important assessment that we will need to do, of course, for any type of neurological diagnosis, particularly involving, the traumatic brain injury, stroke, and spinal cord injury. And then, of course, this would allow us to track any motor return across time, and then also to understand what the person's motor capacities might be for using the limbs for functional tasks. Certainly, we want to look at posture. We'll look at neck posture, trunk posture, sitting balance, standing balance. Those are things that we will incorporate in terms of within our assessments to have a better understanding of the person's capacity to engage in the things that they need to engage in. All right, so how do we assess sensation? It's important to assess with vision occluded or vision covered. And the reason for that is that we don't want the person to rely on their visual feedback to give us an answer, right? We want to assess truly whether or not a person's sensory capacities are intact. And so if they are looking at the test being done, they, of course, are not going to be giving us a true response, or likely won't be giving us a true response. Certainly, we would like to, it would be good to test the non-involved side first for various reasons. One particular reason is that we want to make sure they understand the instructions that we're giving them. And so if the response that they're providing when we're assessing the uninvolved side is accurate, then that gives us an idea, an understanding that they do understand the instructions. And then we want to compare also the involved to the non-involved side. It's important to understand if inattention or neglect is present as well. Sometimes when there is neglect or inattention of a body part, it may present as the person is not going to be aware of the limb, and so we may not necessarily have a true assessment of their sensory capacities, and may be impacted by the inattention of the or neglect. The last thing is communication. If a person has receptive or expressive aphasia, how is that going to impact their response to the sensory assessments in which that we have the person go through? All right, so these are the dermatomes that we talked about earlier. When we assess sensation in the spinal cord injury, specifically following these dermatome patterns, we want to test proximal to distal, right? So proximal is closer and distal is away. When we assess peripheral nerve injuries, we are assessing distal then to proximal. And it's also important to understand that we assess in the order of sensory return: pain, moving touch, and static light touch, and then of course localization. All right, let's go through some of these sensory testings. What is light touch? Light touch is, the person's capacity to determine whether, the person's ability to recognize when they're being touched lightly, of course, in different parts of the body. And deep pressure is, do they recognize pressure on their skin? Sharp dull, as the name implies, is the person's ability to differentiate between a sharp object and a dull object. Localization is the person's ability to identify exactly where they are being touched. Pain, that's self-explanatory. Temperature, self-explanatory to some extent, is the person's ability to differentiate between, of course, hot and cold. Stereognosis is the brain's capacity to utilize sensory information to determine what an object is. And oftentimes when we administer this, we have the person close their eyes and we give them an item to feel in their hands and ask them to identify specifically what it is that they're feeling. 2-point discrimination is the person's capacity to detect two sensory stimulations occurring at the same time, and their ability to differentiate that as that distance between the two sensory stimulations are narrowing. Proprioception is the person's capacity to determine their body position in space, while kinesthesia is the person's capacity to determine their body movement through space. Now, this describes the difference between kinesthesia and proprioception. Proprioception is a broader term, of course, and it does include both the sense of body position as well as sense of body movement, whereas kinesthesia is more specifically the sense of body movement through space. All right, let's transition to talking about the cerebellum and cerebellar dysfunctions. The cerebellum is situated right below, the top portion of the brain and right behind the brainstem. And it is often, it is involved in coordinating movement and adjusting posture. Now, the cerebellum receives, of course, motor information from the brain, the frontal lobe, about voluntary movement. And then, of course, it receives sensory information. It integrates that to allow for the optimal movement to take place. As I said earlier, it is situated right below of course, the brain and posterior to the midbrain, or the brainstem. All right. The interesting thing about the cerebellum is that it is involved in something that's called feed forward. Now, what that means is that, it is considered as a feed forward controller. So what that essentially is that the cerebellum utilizes information from memory of the outcome of prior movements to predict the outcome of future movements. And in that prediction, it then, well, it integrates that, of course, and it utilizes that to essentially work on producing the optimal movement for that the body produces essentially for engagement in any activity. So essentially, it does integrate information from prior movements, stored memory, to predict what the outcome of a certain movement might be, and based on that, it modulates the movement that is about to be produced. So movement in by the cerebellum, of course, it is categorized into three different classes: equilibrium, and gross movement of the limbs, and fine movement of the limbs. Equilibrium is the ability to maintain balance and upright posture by coordinating sensory input and motor outputs. That part of the cerebellum function is essentially linked to the vestibulocerebellum tract. We've talked about the spinal tract in one of the lectures. Gross movement of the limbs is just how fluidly the limbs move through space during a functional task engagement or just during movement production, and that is linked with the spinocerebellum tract. Fine movement like fine motor control, dexterity, all of that is associated with the cerebrocerebellum tract. Apologies about that. All right. A cerebellar dysfunction is associated with abnormal motor execution, and that does not change with or without vision being occluded. So one important thing to know is that with unilateral cerebellar lesion, it affects the same side of the body. So, we understand that in when stroke affects, the right side of the brain, the left side of the body is affected in terms of motor control. But in the cerebellum, it's going to be the ipsilateral side. Oftentimes with cerebellar dysfunction, ataxia is present, and that is tremor. Proprioception may be impacted as well. Of course, there will likely be spasticity, weakness, and all of that as well. Ataxia is just jerky movement, we'll come into the inaccurate movement, but ataxia is oftentimes just the presence of jerky movement or tremor. Disorders that affect the cerebellum are, CVA, TBI, MS, tumors that affect that area, specifically in that area, and things of that nature. There are also inherited degenerative disorders. Outside of stroke and TBI, there's something that's called cerebellar ataxia. And cerebellar ataxia is just the shrinking of it's a genetic disorder. And it's the shrinking of the cerebellum that oftentimes lead to these jerky movements, tremors, oculomotor eye movements, deficits, and things of that nature. Now, how do we differentiate between cerebellar ataxia and somatosensory ataxia, or sometimes it's called sensory ataxia? With cerebellar ataxia, the ataxic movement is present regardless of vision occlusion, whereas with sensory ataxia, when a person is observing the movement pattern, then the ataxia is much less. Different clinical terms that describe ataxia. There's gait ataxia, and as the name it describes, it is ataxia present during gait. Trunnicle ataxia involves the neck, and we'll come actually specifically into some of these. So trunnicle ataxia, limb ataxia, dysdiadochokinesia, this is very hard for me to say, intentional tremor, dysmetria, nystagmus, and dysarthria. So we'll go into them specifically in the next few slides. Truncal ataxia is, you would see the tremor or the wobbliness of that. It's a word of the head and the trunk. Whereas with the gait ataxia, you would see a wide base, unsteady gait, staggering gait. You can actually watch these video when you review these slides, but I'll also display it now. And a lot of times you see the people with ataxia walking with a wide base of support, and that is a compensatory strategy, of course, to be able to maintain their balance. All right, intentional tremor. That is shakiness of the limb during voluntary movement. So, whenever they're moving their arms for functional engagement, you would see this tremor occurring, but you would not see this tremor at rest. Dysdiadochokinesia is the difficulty to produce rapidly alternating movement. So, rapid supination, pronation movement patterns are difficult for people with dysdiadochokinesia to produce, and that's actually one of the assessments that we do to evaluate to see whether or not this type of symptom is present. Dysmetria is the inability to accurately move the upper extremity or even lower extremity to an intended target. And a lot of times when we assess that, we do nose to a target or nose to knee, and we look to see how far they overshoot or undershoot the target that they're reaching, both distally and then, of course, proximally, which is the nose. Dysarthria is related to speech and apraxia that is affecting the ataxia that is affecting the speech.
I feel like a sharpen over succeed. Coco, we can. I'm gonna get no ever.
And oftentimes you would see this with people who have cerebellar ataxia. Nystagmus is characterized by abnormal eye movements, and so oftentimes you notice with people who have cerebellar dysfunction, you notice the nystagmus when you're doing an oculomotor testing. When you're doing smooth pursuit or saccadic testing, you would see the eye shaking, and this shaking could have an upward direction or downward direction or leftward or rightward. So with the upward direction, it would be up beating nystagmus, with the downward, down beating, with the left beating, and with the right beating nystagmus. All right, some other movements that are not typical. Resting tremor. The resting tremor is it's a condition where the tremor is observed when the person is at rest, and oftentimes you see this with Parkinson's. And dystonia is a movement disorder where incorrect messages is being sent to the limb, and there are involuntary muscle activation that cause abnormal posturing of the limb and the fingers and the hand and stuff like that. Allotosis is slow, kind of worm-like movement. Chorea is uncontrolled movement, involuntary, irregular, uncontrolled movement. Bradykinesia is slow movement of the limb. Akinesia is no movement, and rigidity is that the limb is stuck. All right, I won't play these videos. Well, I guess I'll just go ahead and play them. So this is the first part is you see some ataxia. If we go back to this, and then there is dysmetria here as well. So you're missing the target. And there's this little bit of tremor at rest, and there seems to be some rigidity there as well. This is at rest tremor. Okay. Talked about what atetosis is. like so a continuous worm-like movement, as you can see in the person's hands. Okay. Chorea, uncontrolled movement.
Okay, so welcome back everyone. In this video, we'll be discussing about chorea. Now, chorea is a basal ganglia. See that there is involuntary. This is the lesion in the subthalamic nucleus here in this subject. Apart from this, when we
all right, so what is the impact of all of these cerebellar dysfunctions or symptoms of cerebellar dysfunction? Well, I mean, it can impact the person's mobility skills. It can impact the person's ability to do what they need to do on a day-to-day basis, from the basic self-care to IADLs, community participation, leisure participation, driving, work. It could impact the person's ability to perform across many occupations. All right, so in what ways do we assess coordination? These are very good standardized assessments that are used in research and in the clinic and for assessing coordination. The Action Research Arm Test is a great tool, and it has both gross motor, fine motor components to it, and it oftentimes is used to assess arm function for people that are stroke, brain injury survivors, and other neurological conditions as well. The box and block is a quick test. It is a test that allows us to capture a person's gross manual dexterity, and there are age norms associated with, I guess, specific ages. Fugl-Meyer is another tool that is used both in research and clinical practice, more particularly for people that are post-stroke or traumatic brain injury. It also has a gross motor component, it's got a fine motor component, it's got a pain component, a range of motion component. I do really like, actually I love all four tools and I use them very frequently in practice. The 9-hole peg test is a fine motor dexterity assessment, and it's also very quick, and it also has normative values per age group. The finger to nose, I'll play this video.
Okay, good. And now I'm going to hold the cap out here. You can put the pen on. Okay. Good. Good. Another hand.
As you can see, the person has tremor or ataxia, but pretty good in terms of reaching the target. This is the rapid alternating movement.
Can you just tap on one side just as fast as you can, and tap on the other side, and hold your arms like this, and just flex at the elbows. No, yeah, just like this. There you go. And I want you to just take one wrist and just rotate it back and forth, just one side. Just back and forth. And the other side. And the other side again. And this other side. Okay? And now I want you just to pat front, back, front, back, front, back.
And you can see how, the movement is not coordinated. Little compensatory or associated movements, elbow away from the body at times. Movement is not controlled.
Okay.
All right, so some ways to assess gross motor coordination functionally. First, what we looked at earlier are more standardized outcome measures to more non-function based assessments. And then there are various ways in which that we can assess gross motor coordination functionally, although we may not necessarily quantify it as we would with the standardized assessment, but it gives us a good clinical picture of in what ways that these coordination deficits may impact a person's functionally. Tossing a ball, reaching, dressing, folding your clothes, putting things away. So there are a lot of functional ways in which that we can assess a person's gross manual dexterity, gross motor coordination, fine motor coordination. From a fine motor coordination standpoint, handwriting, manipulating small objects, buttoning buttons, zipping up zippers, cutting food, handling money. Those are different ways in which we can look at a person's coordination, but also how a person's coordination deficit may impact functional engagement. Because at the end of the day, what we're kind of focusing on is that what is the person's capacity to engage in functional activities, and how can we improve their capacity to do so. Now, we're going to take a look at the disorders of the brainstem and brainstem dysfunction. So the brainstem is a liaison between the brain and the rest of the body, of course, and it controls basic and involuntary body function. The medulla oblongata it coordinates cardiovascular control, breathing, head movement, and swallowing. The pons processes information from the cerebral cortex and forwards that information to the cerebellum. The midbrain is associated with vision, hearing, motor control, sleep, and wakefulness, arousal, and temperature regulation. Now, some impairments that we would see with brainstem dysfunction, it would be dysphagia, diplopia. Diplopia is double vision. Dysmetria, which is an ability to effectively and accurately reach a target, and dysarthria is impaired speaking. Out of these four, certainly we want to be familiar with all of them, but the two we will more likely evaluate as occupational therapists would be diplopia and dysmetria. Now, disorders of the brainstem, they of course may impact heart rates. They may impact stability of blood pressure, interfere with breathing, depending on, of course, where the lesion may be. One of the disorders that is oftentimes seen, or could be seen when there is an infarct or an insult or a lesion in the brainstem, is a locked-in syndrome. In a locked-in syndrome, the person's consciousness is intact; they are aware. However, oftentimes they do present with a lack of voluntary movement in most of their body, essentially. And in many cases, the only thing that's preserved, of course, is eye movement, and it's a very tough condition. So in not all cases, but in many cases, voluntary eye movement is preserved, and that's one way in which that they communicate is with eye blinking or eye movements, coded eye movements. Wallenberg syndrome, it occurs with lesion in the lateral medulla. It is associated with ataxia and loss of pain and temperature sensation in the ipsilateral side. On the contralateral side, loss of pain and temperature sensation from the body is oftentimes seen. These are frequent sites of brainstem lesions. You can look into this information in the slide. Now we're going to transition into motor learning. Now, motor learning is essential. The reason why it is essential is because what it is. It is the acquisition and modification of learned movement that occurs across time. And essentially the outcome of this is the production of purposeful movement in all extremities, as well as postural adjustments to specific activity demand, right? So for instance, ability to reach and grasp something, and in doing so, the ability to produce the necessary trunk lean or body lean to be able to reach the target, specifically when we reach outside of base of support, without loss of balance. So that's motor learning that occurs across time. Now, it's not just simply about muscle actions, right? It's the interaction of position, timing, distance, speed, right? How do I position my body? When do I time the movement? How much do I need to move? And how quickly? It is a very important concept after any neurological event. And it is, of course, closely related with brain plasticity and the cortical map reorganization concepts that we covered when we talked about neuroplasticity. It is also strongly related with the dynamic systems theory, which essentially postulates that there's, no one system is more important than the others, and motor behavior is through this dynamic interaction between the person's client factors, which is the motor, visual, sensory capacities, and then to occupations in which that the person has to engage in within their specific context. Task-oriented approach is essential for motor recovery, and task-oriented approach is of course, engagement in salient activities within one context, and of course, it is closely related to the PEO model as well, right? The person, the environment, and the occupation in which that the person needs to engage in. From a contemporary motor learning standpoint, there are multiple treatment approaches that are supported by evidence. The constraint-induced movement therapy is supported by evidence, strong evidence, of course. Now, the dosage, there may be different studies that looked at different dosage of it, right? So if I recall correctly, the original constraint-induced movement therapy is like 6 hours a day, but there's a modified constraint-induced movement therapy. And the principle of it is really forced use, and we may come into it in future slides, I think we will, forced use of the upper extremity. Robotics is another treatment approach with some evidence in terms of its efficacy. Virtual reality use is another one, and bimanual training is another one. Again, as I mentioned, the CIMT, it's forced use of the affected upper extremity in order to combat learned non-use. So what happens after a person experiences a stroke and they have hemiparesis on the one side? Because it is difficult to use their arm functionally, they rely on the non-affected side. So over time, there will be a learned non-use of the affected side, even if there is some movement preserved. And so the CIMT is to target that learned non-use, and of course to force the arm to be used more. And what we know about motor recovery is task-oriented approach with forced use of the arm for functional activities is more likely to lead to neuroplastic changes to occur versus root exercises. Constraint-induced CIMT is integrated into this treatment is the concept of feedback. Now, with feedback, there's knowledge of results feedback, right? So knowledge of results feedback is that the person performs the task, and then the feedback is provided and what the outcome of that task completion was with the affected upper extremity. Knowledge of performance is the knowledge of how the arm moved during that task, or how the arm is moving during that task. Oftentimes, knowledge of result is a better feedback than knowledge of performance. And then there's intrinsic and extrinsic feedback. Intrinsic feedback, how the person feels, through with the movement production. Extrinsic feedback would be feedback that is given to that individual either from a clinician or with video recording, and then looking at their performance with a recording after it was recorded, or feedback through a mirror. All right, for the CIMT protocol, there are certain kind of stipulations. For instance, some voluntary extension of the wrist and minimal extension of the MCP and the IP joints should be preserved. Those that are high functioning may demonstrate about 20 degrees of wrist extension and 10 degrees of active wrist and elbow movement. Lower functioning individuals that would benefit from this intervention show at least a 10 degrees of active wrist extension, and 10 degrees of thumb abduction and extension, and 10 degrees of extension in at least 2 additional digits. Additional stipulations or additional requirements, preferably these movement patterns can be repeated 3 times in 1 unit. But across the board, anyone who's low or high functioning could participate in the CIMT. However, I think the treatment approach will have to be downgraded, upgraded based on the person's capacities. Robotics, there are a lot of studies that looked at the effectiveness of robotics in terms of helping motor recovery, with, of course, varying degree of quality and varying degree of efficacy, quality of the study, and then efficacy of the results. Now, there is evidence, of course, that suggests that robotic devices could improve motor recovery and functional outcome. Virtual reality is another modality. Now, there are three types of virtual realities. There's immersive virtual reality, where the person is fully immersed into that virtual reality space. And then there is the semi-immersive virtual reality, which is the person is not really immersed into a virtual reality environment, but they are maybe controlling an avatar on the screen using a sensor. Augmented reality is another one, which I don't think that I've been exposed to in my clinical practice, but this is where virtual reality, people wear glasses, and virtual reality avatars are superimposed into the real space through these goggles or glasses. Bilateral training techniques. There is also evidence that such techniques can be helpful in terms of motor recovery. And clients participate in activities with both upper limbs simultaneously. There are, of course, technological devices that would allow for this to happen, and then bimanual activities can also be simulated without the use of technology. Now, what I've mentioned so far are the contemporary motor learning approaches, and there are evidence-based strategies to utilize. The most effective one, or the most supported one, is really the task-oriented approach. Now, there are traditional motor learning approaches that have been, a significant part of the rehabilitation world in the past, and not so much currently as a primary modality, but these approaches can certainly help guide interventions, although cannot necessarily, they're not superior to the task-oriented approach. All right. Getting my notes out here real quick. Apologies about the pause. All right, so I'll skip the general principles, going specifically into these traditional approaches. The root approach is it uses sensory stimulation to either activate or calm muscles in people with neurological conditions. And so essentially, there are two main goals when it comes to this. One of the goals is to facilitate muscle activation, and then the other goal is to inhibit muscle tone. And by doing so, then the expectation or the desire is to produce optimal motor movement or motor output. And so this is not a primary modality, of course, but using this technique, therapists could try to have the person engage in purposeful activities by facilitating some of these facilitatory techniques, and then also by doing some of these or engaging in some of these inhibitory techniques. So application of quick stretch over the spastic muscle before having the person use the arm to do something functional. Or, for instance, if there is muscle that's not quite activated, for instance, you can have a person engage in functional reach, but the triceps are not well activated for the person to produce the optimal movement, then you can tap the triceps to be able to get the person to engage in that functional reach. So it is an adjunct or complementary to a task-oriented approach. yeah, Brainstorm is the another kind of motor learning theory and developed by a PT. And this was specifically developed for people post CVA. And this is the approach is that the arm goes through certain progression in terms of motor recovery, and the emphasis is placed on facilitating that progression um, from reflexive movement to eventually getting to volitional movement. And so essentially, the theory postulates that there will be a flaccid presentation, spasticity appears, then there's strong movement and synergy, and oftentimes the synergistic movement isn't, internal rotation, elbow flexion, wrist flexion, and finger flexion. And then oftentimes the person starts to break out of this synergy and then gets more motor, volitional motor movement. So these are the different stages of Brainstorm. PNF. PNF is it's called the proprioceptive neuromuscular facilitation, and it focuses on normal movement, but with motor development. So it essentially describes mass movement patterns, not linear movement patterns, but diagonal in nature. And so I'm going to go to the next slide. So there's the D1 flexion movement pattern. There's a D1 extension movement pattern, D2 flexion movement pattern, D1 flexion, D1 extension, D2 flexion, D2 extension. Sorry, going over these slides here. Now, as far as how it could be utilized in therapy, depending on the motor capacity that the person has, we can incorporate these PNF patterns into functional activities where the person is moving objects through space using those DNF patterns, or PNF patterns, I should say. So with D1 flexion, these are the movements that are associated with it. You can engage the person to go through this plane of movement for brushing hair. For D1 extension, these are the movement patterns that are associated. So shoulder extended and abducted, internally rotated, and then elbow extended and forearm pronated. So essentially from that position, and then the person is going to go into the opposite movement pattern as well. And so, working on maybe picking something up and putting it into the closet, those type of, or into a shelf. D1 extension, the application of seat belts, D2 flexion. That's a movement pattern where you go from the arm is extended and abducted and internally rotated, and then the elbow is into flexion, and then you go into the opposite direction. NDT. Now with NDT, NDT focuses on the production of normal movement patterns, and for essentially to essentially help the person achieve what would be considered a normal movement pattern, before, of course, having the person use the arm on functionally. Now, what currently is best practice is that facilitation of normal movement pattern is not necessarily, we're not going to spend heavy amount of time for that. What we're going to spend heavy amount of time on is forced use of the arm in different functional tasks, whether or not the movement pattern is normal or abnormal. But how do we incorporate NDT into our clinical practice? Well, as a preparatory task, you can have the person do weight bearing on a countertop, and after that, you then transition into having the person use the arm functionally as much as possible. And of course, the capacity with which that the person uses their arm is going to depend on how much movement the person has, right? a flaccid upper extremity is not going to be used functionally. But there are ways in which that they can be incorporated, right? We can incorporate a flaccid upper extremity as a dependent stabilizer when the person is engaging in a functional task. For instance, if they are writing, holding the paper down with the arm and using that as a dependent stabilizer. That's one way that a person can engage, can involve the weaker arm. But at every step of the way, in terms of motor recovery, we could be creative in figuring out ways in which the arm can be incorporated into functional activities. All right, I think the rest is for the lab. Again, if you have any questions, it's a long lecture, I get it. But if you have any specific questions, if something in this presentation or in this lecture is not clear, please feel free to email Dr. Glover or myself, or bring it to lab, and we'll be more than happy to essentially answer or clarify anything that needs to be answered or clarified. Have a wonderful day.